Good afternoon, everyone. I just want to welcome you all to another episode of Office Hours. Today, we're going to be discussing lessons from critical access hospitals RCM case studies. This is going to be kind of a neat episode as we have Ron Kero on as well. He's Chief Development Officer with our division, Ni2. Ni2 handles a lot of our acute side of the business, hospitals and some large health systems. So some really good findings that we're going to hear from Ron today. How you doing, Ron?
Hey, I'm doing great, Stuart. Thanks for having me today.
That's awesome. That's awesome. So just some housekeeping real quickly as if you've been on our episodes before, we will have some Q&A at the end. So I encourage you to just click on that Q&A box. You can actually enter a question there and we'll be able to answer that at the end of our episode today. So before we dive into exactly these case studies and these findings, Ron, I just wanted to, so if you could just take a few moments to talk about the current landscape of critical access hospitals, particularly the attitudes of administrators and CFOs regarding their RCM.
Yeah, my goodness, what a challenging environment they have today. You know, first, recently through COVID and just the immediate post-COVID was how do you stabilize all of your staffing and operations? And they get through all of that, and then you realize, shoot, my staff costs more, my supplies cost more, my drugs cost way more, but none of the insurance companies have offered to pay me anymore. And, that's really caused this, I'd say, relatively recent renewed focus on just financial operations. I was just at the American Hospital Association Rural Healthcare Conference. Financial stability is one of the big subject categories for everyone. And I was just seeing some statistics on critical access hospitals where it was reported that over 70% of them have a negative operating margin, even after considering all sources of income. And many of them are really struggling now just to make payroll and survive. And
Wow.
so we're in this environment where literally every dollar does matter. And right, the biggest place to look is at your revenue cycle. And so, yes, it is definitely getting a lot of attention now due to just the pressures of the financial environment.
Well, and I can imagine many of them don't know where to start, right? So there probably is a resurgence in analyzing their processes and analytics. Do you find that to be the case?
Oh my goodness. As I talk to CEOs and CFOs across the country, I mean, it's pretty universal. My team is working at capacity. I've got too many initiatives. I don't know how we could take on another one. But their challenge is they don't know which of those opportunities are going to make the most financial impact for their organization. They're really flying blind with respect to, what's the value of one initiative versus another. And if you have too few resources and competing priorities, having those insights, is something that I think every one of these organizations could benefit from. And hopefully we're gonna make a contribution to that as I share some of our case study findings for what we're seeing across these hospitals. And I'll give you a little teaser here. The biggest lift is not the usual suspects.
Oh, I bet it's not. And so it sounds like they still operate in silos. That seems to be a continuous problem anywhere in the healthcare industry, not just critical access hospitals. But I'm sure there's other barriers that they are facing. One that comes to mind would be something like IT and also the excuse of we just don't have the bandwidth. They may not admit it, but it's like just another task that's added to their agenda that they just cannot get to.
Oh, they admit it. I'd say pretty freely today, right? It is very common here. Boy, we know we've got all these opportunities. We can't seem to get to them. Our teams are already way too busy. And so, yeah, I think the challenges, right? In your community hospital, you have the local expertise that you have, right? And so you have to work within the capabilities of your talent pool. And oftentimes that team doesn't know what they don't know. And then, right, you have a really small IT team. And so, right, if there's any part of the organization that seems to touch all the other parts, it's IT. And so nobody has any excess IT bandwidth either. And so one of my soapboxes for when I have conversations is think a little bit out of the box. Don't be a prisoner of your budget or your staff resources, right? There are ways to partner with, other companies or, business consultants who can bring the expertise and maybe do it in a way that doesn't impact your budget constraints. For example, if you have a contingent type of relationship where you pay them out of benefit you didn't have before.
Right, right. Well, that makes a whole lot of sense. So it just has a coming together and make sure they not only assess their RCM uh, processes, but also what teams this affects, and is everyone going to be rowing in the same direction, so to speak.
Sure, sure.
So now let's diving into the assessment itself. Can you set the stage with the assessment that was done across 40 organizations? What was the approach that you took?
Yeah, yeah. So we do comprehensive end-to-end assessments of our client revenue cycles from point of patient registration until you do everything you can to collect or write off, the balance for the client and patient invoices that you gave. It's an extremely granular look, and we go so far as to actually rerun every line item of every claim for the prior 12 months through a couple of different technology platforms that we leverage to help us identify opportunities for the organizations. And it's interesting that, right, we find some very common needs across all of the kind of rural healthcare critical access hospital environment. And then we find other areas that are very, I'd say, specific to the local community and the talent pool and resources that they have locally. And so it's kind of some things, I'll call it a foundational set of needs that seem to be common across the critical access hospital environment, and then others that are more local specifics determined.
Got it. That makes a lot of sense as well. So you got to set a baseline, so to speak. Look at some common culprits, if you will,
Yep.
and then some opportunities that people may not have thought of, kind of out of the box, so to speak.
Yep. No, that's right. So I'll uh, kind of jump to the findings here for, right,
Sure.
what have we learned? What's the real insights? Because I said we're going to help with this prioritization of opportunities. You know, I think for most people, when you think about where do I likely have opportunities, most people think about billing and collections, or they think about denials. Those kind of come to mind first. Those are not the common areas that we find. Again, that doesn't mean there isn't opportunity for individual organizations. We have found one universal opportunity, meaning for every hospital we've assessed, and this is actually an opportunity not just in the critical access market, but for hospitals of all sizes,
Hmm.
and that is charge capture optimization.
Wow.
At the most simplistic level, it's just making sure that you bill for every service you provide to every patient every time, right? That's the simplistic way to look at it. Right? It's a little more complex than that, or it wouldn't be such a big opportunity, right? But at the foundation, that's what it is. We find that 100% of critical access hospitals are leaving money on the table. I call it, right, unintended charity care by providing services, and they're just not billing for them. And
Right.
this is not a critique of the hospitals and their expertise. What this says is it's a very complex environment for what you can bill for, and then for clinical rules to make sure it translates to patient bills every time. And so, without specialized technology, And without specialized experts to know what you can bill for, and then without specialized experts who know how to tweak the clinical workflows so that you do capture this stuff, you can't get it right all the time,
Right.
right?
Right.
That's just the reality of it. And so here's the other shoe to drop. It is the largest opportunity. And it is probably the single largest operating margin opportunity for all hospitals across the entire enterprise, not just looking at revenue cycle, but operations as well. So we have found that the average net revenue lift across our client base has been 1.5% to 2% of total net revenues. I'll say that
Yeah.
again. 1.5% to 2% of total net revenues. Think about that in the context of so many of the hospitals that, right, have a negative net income. This is a huge opportunity. Now, the caveat is that that opportunity is not the same across the country. So the predominance of the benefit is going to come from commercial outpatient contracts for hospital services. How hospitals get paid for outpatient commercial varies quite a bit from state to state.
Mm-hmm.
Okay. So we have some states where all the contracts are a high percent of billed charges. So it stands to reason if you find something that you hadn't billed for before and you fix that revenue leakage, you're going to get paid a lot for what you now are billing. There are a few other states where there isn't any percent of charges left. It's all fee schedule based. And we may add some things to claims, but it may not translate to much net revenue. But I would say it would be very unusual in the critical access hospital space for us to find less than 1% of net revenues. We have many clients where it's been more than 3% of total net revenue.
Oh, wow.
Yep.
That's amazing.
Yep. Yep. And we can circle back to charge capture a little bit more. But I want to kind of finish the high level. What do we find?
Sure.
The next two most common needs in revenue cycle, and there's only three that we find are common pretty much across the whole market sector. The second is what we call strategic pricing. Most hospitals annually just do across the board increases. Maybe your Blue Cross contract says you can raise your fees by 3%. So they raise their fees by 3% year after year. Our definition of strategic pricing is that we will pull in the fee schedules of any peer organization that the hospital wants to be benchmarked against, find out how do they want to be priced versus their peers. Are there some local market things that are price sensitive? Sometimes MRIs or some outpatient services, there's some competition. And we rerun all the prior year's activity through another very sophisticated software engine that allows us to come back with a recommendation of increases and decreases that keep the hospital priced where they want to be against their peers, maybe provide some more, I'd say, rationality to a price to their fees, which may have kind of evolved over time, but increase some more than that 3% in areas that generate, more outpatient commercial reimbursement and decrease some other prices where it doesn't really matter and are able to get some additional lift over that 3% cap in the example, but still be compliant with the 3% cap. So we find about 80% of the hospitals out there haven't done this. And so it's a real opportunity for them. And the last one is just reviewing their charge description master to see if they have any compliance risks, right? What do they need to update? Again, this is a super complex environment. There are updates every quarter. Last year, as we assessed our client CDMs, we found on average about 2,600 required compliance edits, right? Now, and again, that's not surprising because it's where you're going to find one of those experts to do this in the community. And this is not a revenue generator directly. It's it's addressing a compliance gap
Right.
within the revenue cycle team. And what's nice is when you package it with some of these other revenue lift opportunities, you can actually fund this compliance risk need out of revenues you didn't have. So you don't have to, right, dig deeper into your existing budget to come up with the funds to do it.
Right.
Yep. Otherwise, the billing and collections, we do see that as a need maybe a third of the time. And that can take a bunch of flavors. It can be Susie just retired. There isn't anybody else who's done this in our community. I can't fill this position. Okay. It can be, we got this backlog. We can't seem to get out from under ourselves and just get caught up. Or it can be, we just don't do this very well. We might be better served by somebody else taking this on for us. So whatever that need is, those all fit into billing and collections. It's about a third of the organizations. And but it can be a significant opportunity where there's that need because of the locally available resources.
Wow.
Everything else, right? Everything else, denial management actually doesn't tend to be as big an issue in the critical access hospital market because it's just not as complex as, the big medical centers. And when you have less complexity, you tend to have fewer denials. Not to say there aren't. I definitely we have had some organizations that struggle like with prior authorizations being a significant driver of denials. But again, that's very local circumstance specific as to where that's a need. And other things just about patient self-pay collections, organizations. We see some who haven't had anybody to renegotiate their payer contracts for a long time because they didn't have anybody who could do that. Just make sure your commercial payers are paying you accurately, right? Those types of things, right? There are needs, but those aren't where the big payoffs are typically for the critical access hospitals.
Oh, excellent. And those are all three big, huge points that I don't think a lot of people are really thinking about. So it's really thinking or rethinking, if you will. What do we need to be looking at? It's like you said, we don't know until we don't know. And then when we do know, what do we do about it? Where do we begin? So
Absolutely.
yeah, so when we you mentioned let's do a deeper dive into this notion of charge capture optimization.
Uh-huh.
So if you could tell us what that means to leverage that a little bit more, so kind of expand that a little bit.
Yeah, yeah. And this is, as I said, it really takes the combination of specialized technology
Hmm.
with specialized experts. And so we have invested in our own proprietary charge capture technology platform. It's got an 18-year history. It literally has 1.6 million algorithms in it. The first couple 100,000 are simply looking to make sure that the hospital is billing compliantly, right? And so we look for those things, and we do find opportunities to change how some things are billed for certain clients so that they
Hmm.
can be compliant. But the rest are all looking for, based on all of the 18 years of learning, right? If there is
Right.
a specific line item on a claim, is it possible there's another service that you sometimes see on a claim, but it isn't on this one, right?
Yeah.
So as I said, we will run every line item of every claim for the prior 12 months through that technology platform. On average, it flags 17% of all the claims for further review. Now, by design, most of that's going to be false positives because there
Hmm.
are services that don't go together very often. So you have to have a lot of false positives to find those where it was missed. And we then take the output of that and hand it off to our team of specialized charge auditors. And all they do is look at our client medical records to see for those flagged claims if the service was actually documented in the medical record. So they remotely do that. We're very efficient at it because they know exactly what to look for, right? And it's the kind of thing you can't just spot audit or have people on your team trying to catch these things. There's too many claims and it's too complex, and there's too many things you could miss. You really need technology to be that first comprehensive scrub of this. what we find very consistently is 8 to 12% of the claims that are flagged are missing a service that the hospital provided. So if you walk that backwards to overall, call it 1.5 to 2% of all hospital claims are missing a service that the hospital provided to their patients.
Yeah, that's a lot.
Yep. And it's never just one thing. I'd say we average 15 to 25 different initiatives for a small critical access hospital. And we've got clients that are as small as, call it, 9.5, 10 million in annual revenues. That's a less complex environment, even in the critical access world, right? There are only maybe 12 to 15 initiatives for them. We've got other critical access hospital clients that are closer to 100 million. More complexity brings more initiatives. So for those, right, we'll typically find 15 to 25 different types of revenue leakage related to charge capture.
Oh, nice. So, um, thinking back to the IT challenges that were discussed in the beginning, it looks like Ni2 has that covered. Is it a seamless experience for the clients that you service?
I appreciate you bringing that point up. Again, nobody has IT bandwidth.
Hmm.
So we had to build our own team of IT experts. We have clients who are on all of the EMR platforms. In fact, many clients on all of those platforms now. And so we have already written the scripts to extract all the data we need out of those systems to assess our client opportunities and then to measure how we're doing helping them going forward. And so you really have two flavors of IT out there in the critical access hospital market. Those that are standalone, so they're on Meditech, they're on Cerner, maybe Cerner Community Works, maybe it's Athena, maybe it's CPSI, right? In those environments, literally the only IT help we need is to be granted system IDs and system access for a handful of folks. And we go in and pull that data, but our clients always know what we've pulled because we store it on a client server. So they always have a copy of what we get. And then we upload that securely to our cloud platform, which is where we do all our work in our own environment. The other flavor is the hosted environments, usually for Epic. We have a number of those. And so, again, in that situation, right, the work that is needed is really not from our client, but from their Epic sponsor host system. And we've partnered with many of them. And it's each kind of a custom conversation to find out how much of the work their team wants to do and how much they'll let us do. But we form
Hmm.
that partnership. And so that's how we solve the IT part.
Oh, awesome. More like a collaboration. And
Uh-huh.
everyone has transparency to what's happening. So that's awesome.
Yeah.
But you've given us a lot to chew on here. So I just want to ask, are there any other opportunities for optimization that most administrators or CFOs just don't consider? Again, they don't know what they don't know, right?
Yep. Yep. So I'll say that our charge capture initiatives are a mix of things that the hospital may be billing successfully some of the time, but not all of the time.
Mhm.
For those, we'll figure out why are they missing it some of the time and come in and actually fix the root cause of that so that they successfully bill for those 100% of the time, not half the time. And a simple example, but it's true. I just sat in on one of our client assessments where for one service, they were getting it right half the time, missing it half the time. Well, he had two people who covered the service. Guess
Oh,
what?
wow.
One person was doing it right, the other person wasn't. Nobody had any idea, right? Because they didn't know where to look. I'd say we also do see for sure occasional services that the hospital didn't know they could bill for, right? And it can be, somebody 10 years ago said you can't bill for it. And right, that was never questioned again.
Right.
Or it can also be things where maybe someone on the revenue cycle team does believe you could charge for it, but the clinical leadership doesn't think so. And so you have a little bit of an impasse inside the organization because you don't have what I like to call a single source of truth.
Right.
Right. And so that's something that we're able to bring to our clients because we specialize in this and we do this all over the country. We're able to, right, where there's differences or multiple opinions inside the organization, we can resolve that with, that source of truth. I'll say the last thing, again, thinking about insights, just about every critical access hospital has a pretty significant outpatient physical therapy and occupational therapy program, right? It lends itself. Most have at least a couple of therapists. What we have found is that in the hospital environment, and this is not just true for critical access hospitals, but true in the hospital landscape, that the therapists all undercode for what they actually do for the patients.
Mhm.
So they
Yeah.
don't bill at the full intensity. And that, this is one where best clinical care goes hand in hand with documenting your billing according to that best clinical care. And so we have found that with mentoring, we're able to coach up the therapy teams to better reflect what they're actually doing when they bill their patients. And so across our clients last year, we increased outpatient PT and OT revenues by 21%.
Oh, wow. Yeah.
Yeah. So, I mean, that's something that you wouldn't think of, right? And so, right, we've got lots of those nuggets from our journey, but I think we've done a pretty good job of hitting some highlights here.
Oh, that's awesome. Yeah. So I guess the next question would be, how is this all put into action? How does it get started? What's the process?
So the process is that when we partner with one of our clients, it is for us to do the assessment. And again, let's get back to we started. Nobody has bandwidth. We know that. And so we've structured everything we do to be bandwidth additive. So meaning, right, not only do we do the IT stuff, we do all the analytics, and then we do all the execution work so that the client teams, because those plates where you can't add one more thing to those plates, this isn't adding something to their plates. And in some ways, it's taking things off of plates because anything related to what we're resolving that they kind of had fires to deal with, they no longer have to deal with. But I'll say what is very unique with what we do in helping the critical access hospitals is in particular for charge capture is that we actually will come in and fix the clinical workflows, bring kind of best practices so that you capture all of these things that you were missing before from a billing standpoint. You capture them before the bills go out going forward. It takes us 3 to 4 months typically to do that and kind of complete all of those initiatives. But yeah, we uh, we also are on a contingency structure, so we don't invoice our clients until they actually bill out revenue they never had before. And so you can think about, right, we've kind of solved the IT barriers, we solved the bandwidth barriers, and we've solved the budget barrier in trying to help these hospitals. And I'd say, the other thing that I think we're very proud of is actually we deliver on our promises from the assessments, right? And so we just took a look back over the last dozen assessments we've done. What did we see in the assessment? And then what was the actual benefit that we delivered to our clients? Delivered benefit ran 120% of assessed benefit. So, right, that's something that we're very proud of, in working with our clients is that, right, this is real revenue to the organizations. And again, in an environment where it is so hard to achieve financial stability, this is a path to making a big step in that direction for organizations.
That's fantastic. Well, to wrap things up, just want to kind of give a summary, but what are some key charge capture factors that maybe we haven't addressed?
Um, I'd say, in within charge capture, anywhere where there are complexities in an organization, so the emergency department, outpatient surgical services, recovery, anesthesia, anytime you're administering drugs or fluids, and you have a service you're providing as well, bedside types of procedures, all of those are pretty common areas for us to find. Again, we're going to, right, as I said, we're finding, call it 15 to 25 initiatives, but it's going to be where the complexity is. Now, we do assess all the entire enterprise. So, right, many of our clients have rural health clinics and other operations. We look also at how they're doing, and sometimes we do see some revenue opportunities there as well. But that environment is much less complex. And so it is rare that that's more than 5 or 10% of the total opportunity that we find. But we certainly look across the entire enterprise.
Well, that's awesome. So just want to open it up for questions. We'll, as I said earlier, if you could put your questions in the Q&A section that's provided by Zoom, we'll be happy to address those. So we have, I do have a question here. Is this being, I guess this being claims or encounters or charges being corrected, then resubmitted, or is this more preventative for future claims?
Oh, I'm glad that we got that question. So, right, there are other folks who help some organizations with charge capture. Those are usually a SaaS model, just providing technology for hospital teams to leverage and find missed claims. It's not really targeted towards the critical access hospital market because there's not the resources or the expertise to take the output of those SaaS models and turn it into action. But in that environment, it is generally rebilling claims, right? You find a claim, you miss something within timely filing, you go and rebill it. And our approach is actually the opposite of that, which is let's start by fixing the root cause. So there's no need to rebill claims. You get it right going forward.
Right.
Certainly, when we do the assessment for our clients and we find opportunities to rebill within timely filing, if our clients want to go out and capture that revenue, we can easily hand them a file of every one of those claims, and we'll be able to tell them how much they're actually going to collect from each one of those.
Wow, that's amazing. So it's really more of a proactive approach, making sure you're not leaving anything on the table, squeezing blood out of the turnip, as they would say, to make sure you get every single dollar you can and didn't know you could get. So that's awesome.
Correct. Correct.
Uh, so we have another question here. Can you briefly discuss how an optimization project will eventually lighten the workload of clinical or revenue cycle staff? And I know that typically there's clinical and revenue cycle staff. Some people like to split that. It's two separate areas, but I think I like the way this question is phrased there for clinical, or I would like to say and revenue cycle staff.
Yeah. Yeah. Well, I like that question. Let's start with the revenue cycle staff, right? A lot of time as I talk to revenue cycle leaders in critical access hospitals, they describe their days as they're in a hamster wheel of fighting fires, things that come up, and they've
Mhm.
got to track them down and research them and put time and energy. But these things can be a bit like Groundhog's Day, right? I just did this one yesterday, and 2 days from now, I have that same thing that's come up. We don't ever get to resolving it, but it's a part of that daily workload.
Mhm.
And so, right, with the work that we do in particular with charge capture, it will, after we finish our implementation work and rework the clinical workflows, all of the firefighting around charge capture, or folks asking, I wonder if I missed this, let's go audit some claims and see. That all goes away because we continue to provide 100% audit every month going forward to make sure that there are no right that all the things that we found, the client is sustaining the benefit. I'd say for the clinical teams, there is a little bit of work in the areas where we have the opportunities to get to the bottom of what's causing us to miss billing for something every time, and then implementing the best practice new workflows. One of the things that we do to help with that, because hospitals are 24/7, so you can't ever get your entire team who touches different clinical areas into the same meeting at the same time. We actually make training videos
Oh,
of
nice.
each of these, and we give them to our clients so that for their people who work different hours, or when they have turnover, or people change, they now have a library of training videos that they can use so that when their environment changes,
Hmm.
they can still sustain the benefits.
Well, that's
So,
amazing.
yeah, but this then also, right, again, there is angst when there's kind of, things that there's uncertainty in the organization. Are we doing this right? Are we
Hmm.
missing something? All the energy related to that goes away once we've, addressed all of the charge capture optimization initiatives. So it does, after, implementation, it does free up whatever part of the daily, workload was looking for those things or addressing those fires.
Well, that's awesome. Well, it doesn't look like there's any other questions. I'd like to thank you, Ron, again. Always a wealth of knowledge. You just know what you're doing, and I really appreciate you taking the time. Just got off a plane. I know,
Yeah,
just got off a plane from seeing a client. So really appreciate you just taking your time to speak with us today on this episode of Office Hours. And
yeah. No, Stuart, I really appreciate the opportunity. And I will say, right, we as a team are very passionate about helping critical access hospitals survive and thrive.
mhm.
And we're proud of the impact that we're making in those communities.
Yeah, that's awesome. That's awesome. Well, and that wraps up this week's episode of Office Hours. Just encourage you all to look out for next week's Office Hours. It's going to be the same time, same channel, just a different subject, and that'll be announced here shortly. And be looking forward to see all of you there. Thank you
All
so
right, thanks,
much.
Stuart.
Thanks,
Cheers.
everyone.
Bye-bye.
Bye bye.